So androgen-secreting tumors. These are the rare tumors of the ovary or the adrenal gland, which may be benign or malignant, which may cause virilization in females through the androgen production. And epidemiology and pathology. So basically there are two sources. One is androgen-secreting ovarian tumors, and the other one is androgen-secreting adrenal tumors. The androgen-secreting ovarian tumors, 75% develop before the age of 40 years and account for 0.4% of the all ovarian tumors. 20% are malignant. Tumors are 5 to 25 centimeter in size. The larger they are, the more likely they are to be malignant. They are rarely bilateral. Two major types are sex-coat stromal cell tumors, often contain testicular cell types. Adrenal-like tumors often contain adrenocortical or Leydig cells. Other tumors include gonadoblastomas and teratomas, may also on occasion present with virilization. So overall, sex-coat stromal cell tumors and adrenal-like tumors accounts for majority of these tumors. Androgen-secreting adrenal tumors. So 50% develop before the age of 50 years. These are larger tumors, particularly those greater than 4 centimeter are more likely to be malignant, usually with concomitant cortisol secretion as a variant of Cushing syndrome. 40% of the ACCs present with Cushing syndrome, 25% with both Cushing and hyperandrogenism, and 10% with hyperandrogenism alone. There's increased chance of adrenocortical carcinoma rather than adrenal adenoma. Clinical features include the onset of symptoms, usually recent onset of rapidly progressive symptoms, hirsutism of varying degree, often severe, male pattern balding, and acne are also common. Usually oligo or amenorrhea, infertility may be a presenting feature. Virilization indicates severe hyperandrogenism. It is associated with clitoromegaly, and it is present in 98% of the female with androgen-producing tumors. It is not usually a feature of PCOS. Other features include abdominal pain, palpable abdominal mass, ascites, and signs and symptoms of Cushing syndrome presenting in many of the female with adrenal tumors. Investigations include a total testosterone greater than 5 nanomole per liter should prompt further evaluation for the testosterone secreting ovarian or testicular tumor or ovarian hypertrichosis. Start with the ovarian ultrasound and consider adrenal imaging if ultrasound is negative, a high DHEA. Occasionally, venous sampling of the gonadal vein for androgens is needed. Greater than 50% suppression testosterone suggests ovarian in origin. 90% of the DHEAs are produced in the adrenal glands. They are weak androgens, but small amounts are converted to androstenedione and then testosterone. The concentration of DHEAs are 100 to 1000 times higher than those of the DHEA. DHEA do not strongly identify an adrenal malignant cause of hyperandrogenism, although values greater than 18.9 micromole per liter required further evaluation. So if there's a short history of hirsutism and virilization, that is weeks or months, then first of all, check the testosterone. If it is greater than 5 nanomole per liter, then check the DHEA sulfate, which is increased in adrenal tumors, androstenedione, which is increased in ovarian tumors. 17 OHP may be increased in both the conditions. Exclude CH. Check the urinary free cortisol, which is also increased in adrenal tumors. Get the ovarian ultrasound, MRI and adrenal glands and ovaries can also be considered if the ovarian ultrasound is inconclusive. If both the images are inconclusive, then selective venous sampling should be undertaken. As far as the management is concerned, surgery, adrenalectomy or ovarian cystectomy or oophorectomy should be considered in these patients. It's curative in benign lesions, adjunctive therapy, malignant ovarian and adrenal androgen-secreting tumors are usually resistant to chemotherapy and radiotherapy, spironolactone CPA if the lesion is benign. As far as the prognosis is concerned, in benign tumors, the prognosis is excellent. Hirsutism improves post-operatively, but clitomegaly may persist. Male pattern balding and deep voice may persist. So overall, there is improvement of the hirsutism, but clitomegaly, balding, and voice would not change. When the tumors are malignant, then there's a 20% 5-year survival. Most of our metastatic disease at the time of surgery. In case of ovarian tumors, there is 30% disease-free survival and 40% overall survival as at 5 years. So in case of malignant tumors, overall the prognosis is very poor in both the adrenal tumors and the ovarian tumors.